Good afternoon, everybody. It's Friday, July 17th, 2020. It's 1 o'clock in the afternoon, and you joined us for the CAF COVID Weekly Roundup. We're going to talk about a bunch of stuff today. We've got a bunch of good stuff. I see some people, quite a few people still logging in, so I'm going to give it 1 or 2 more minutes before we get started. So give us 1 second. And just as a general reminder, before we get started, today's slides are in a handout over on the right-hand side. You should see it where it says COVID Weekly Roundup. And just a bit of housekeeping. If I'm assuming everybody that's listening now has registered through the CAF site, but there's kind of, since we switched in July to doing these webinars with CEs attached to them, we had to do a different registration process to be able to do the CEs. So if you've not, I'm assuming most of you guys have, but if you've not, just know that you have to, if you want a CE for today's webinar, or for any of the webinars, you have to go through the learning management system on CAF if you've not registered through CAF. So if you watch the webinar on GoToWebinar, and then you go, oh gosh, I wanted CEs for that, you'll have to go back into the learning management system and go through that process in order to be able to get your CEs. We can only do the CEs through the learning management system. If you don't need CEs, no problem. You can log in through the GoToWebinar link. You can watch it on YouTube afterwards. Both are acceptable. All right, so we gave it a couple minutes for some more folks to get on. We've got a full agenda, lots of topics to talk about this week. So we'll cover the AFLs that are applicable to us. There are a few that came out this week that definitely have applicability to us. We'll talk about testing because that's definitely the subject that has the most consternation and has the most issues with it statewide. It's not just a local issue in your area, it's all over the state. We're going to talk about best practices and how we can model that, and I'm going to ask for your guys' help in identifying what those are. And then we'll talk about PPE supplies, as well as some other stuff that have come up. And we also know that there's an AFL that's pending that's probably going to come out tonight or very, very soon, that's going to redefine some of the reporting that we're going to be required to do, especially as it revolves around the testing. So with that being said, let's get started. As always, we've collected some resources for you on our CAF.org coronavirus website. Generally, these are links to other things that we have identified that are applicable or important for you. Some of them are best practices, some of them are AFLs, some of them are guidance documents from various government entities. My name is Jason Belden. I'm the director of the Emergency Preparedness Program at CAF. I don't believe Patty's going to join us today, but she contributed to some of the work in the slides here. So let's hop right into it. So today's the 17th. Knowing this in the past week, since last Friday, we really had 2 AFLs that came out that have significant impact for our facilities. And I know you guys get tired of me talking about PSPS, but I use it as an opportunity to talk about some of the other things that are consistent for all of us. But just know that if you're in one of the areas that is subject to PSPS events, and you want to know what CDPH requires of you as a facility for notification and all that, there's an AFL that is pretty good about specifically listing out all the points of contact that we need to make if we're a part of a PSPS, as well as what kind of information you're going to want to be sharing with everybody. And this applies to everyone. So even if you're an ICF facility or another type of facility, not a SNF, this still applies to you if you're licensed by CDPH. This counts as an unusual occurrence, and so if you're a clinic or a hospital or anything, any type of healthcare, you're going to need to make notification to folks. And what does that notification look like, and who do those and who is on that list that needs to be communicated with? So the district office, obviously, we know. In this instance, we're going to advise the local health department. Generally, as a best practice, they're less, they're lower down on the list because they're not involved in the day-to-day operations. But because we're currently, they're currently trying to manage a pandemic, that situational awareness of you being without power is very important, because it may inform their decisions to do other types of things within their jurisdiction. So we want to let the district office, the local health department know, as well as the MOOC, or the Medical Health Operational Area Coordinator. Everybody should be familiar with that term now. If they weren't before this, they certainly are now. And the type of information we're going to relay to those folks is, what is the status of our generator? So let's say we've received notification that we're going to be in PSPS. We'll talk about what actions you should be taking once you get that notification. But once the PSPS occurs and it starts, the information that those three entities need as generator status is your generator operational. That's really important. If your generator is not operational, obviously we'll move on to, the kind of evacuation or shelter in place kind of activities that you would do. They're also going to want to know fuel supply and how long that fuel supply you anticipate that to last. Any operational issues that you're currently dealing with as a result of the loss of power, and any resources that you may need to help you stay operational. Because the goal is not, we never want to see facilities have to evacuate when it's not absolutely necessary to protect their life. And so everything that all of these government entities want to see from us is to stay sheltered in place for as long as possible until that's no longer safe. So if there are resources that you need in order to be able to accomplish that, the MOOC and the district office will work together to try to find those resources. I think the MOOC is primarily going to be your person when it comes to that, but it could be the district office, it could be the local health department, depending on what resources you need to stay operational. Like I said, it applies to everyone. If you're wondering, gosh, I don't even know for sure whether I would be subject to PSPS, and not every one of these utility companies has been great about notifying you and what your exposure or what your risk is. But my suggestion is to verify and confirm that the contacts that each one of these three utility providers have for you. And it used to be last year or the year before, when we first started doing these PSPS events, that they would only have one point of contact for you. And that point of contact was a billing person. And that billing person may or may not even be at your facility. They could be a corporate person or whatever. So now they've heard loud and clear that we need multiple points of contact. So call your utility company, make sure that you have at least 3 points of contact, so that if you're indisposed as an administrator, somebody else at the facility or from a corporate level is getting these notifications that you're going to be impacted. This is much, much bigger for PG&E than it is for SoCal Edison and San Diego Gas and Electric, but just know that there is exposure with both SoCal Edison and San Diego Gas and Electric. They have facilities within those footprints. All right, so let's talk about, I know that, that's only 150 facilities in the state or 100 facilities in the state. You go, well, the rest of us, maybe that's not as important. But loss of utilities, whether it be from a PSPS situation or not, and especially under the current situations, would definitely qualify as an unusual occurrence, requiring you to report those as well. So that same kind of reporting, district office, local health, and MOOC, we want them to have situational awareness, because they use that information as a basis to determine where resources are needed. And they can pre-stage stuff. perfect example would be, you have a generator that fails to switch over. Your transfer switch doesn't switch over, and so you just have emergency lighting in the building and nothing else. We've run into situations in PSPS events where the facility called the MOOC, and the MOOC gave them the name of a vendor that had temporary generators that they could use, and they brought a temporary generator and a transfer switch in to run the building until they could get their power restored. So it's things like that that we can work with our partners. Those resources aren't free. We'll obviously have to pay for them, but those resources at least exist. And the only way that the MOOC can understand and try to look for those ways to help us is if you give them that situational awareness and let them know what's going on in your building. So one of the things we can all do prior to the loss of any utilities is just review one, we want to look at what is the capacity, especially during summertime, to have our HVAC system. Is it connected to the generator? Are some of the units connected to the generator? Where can I cohort people if I can only cool a portion of the building? And does that cohorting then expose folks to COVID when they wouldn't? So we have extra things that we have to think of in terms of how we normally deal with loss of power. So I need you to review how you're going to bring in temporary cooling measures, if that's a part of your plan. Make sure that we're not going to be pushing air from for lack of a better term, the dirty side of the building to the clean side. And that's such a stigma. I shouldn't use that. The COVID positive side to the COVID negative side. So we'll also want to review our fuel capacity and runtime. If you don't know that, chances are you probably have already been asked this at least once or maybe multiple times during survey, but at least understand what the fuel capacity that you have on site and what that runtime is. The expectation is obviously 96 hours. The reality is maybe you don't have a spot to store 96 hours worth of fuel, but you have a process to get that fuel in order to stay self-sufficient for an extended period of time. We want 96 hours to be the minimum, not the maximum. So, have a process that says, I've got 72 hours here. I've got a contract with this vendor who says they can respond within 8 hours to bring me diesel fuel, and they could bring me this much at a time. Review all of those kind of agreements you have with those vendors prior to the loss of utilities, especially if you're a COVID positive facility or you have COVID positive folks in your building. There's another layer to how we prepare and protect the residents in the building that are currently COVID negative. And so I just want folks to be cognizant of that, and that a lot of that is covered in the AFL as well. Many of you guys saw this AFL 2038-3, so the visitation AFL. We had many conversations about this last week, and God, what a week does to change things. But I think we've now gone back to really not looking at indoor visitation particularly soon. The CDPH has been pretty clear that they defer to the local health departments in this respect, but they have kind of a guidance document that they want you to follow. And really, we should not be going anything that's less conservative than what the recommendations are. So for end of life, this one is important to us. Visitors are essential to mental health. This is all still consistent with what they sent out before. We've not really talked about the ICFI IDs, but they definitely are allowed to have a presence of a support person. And then for hospitalized patients that are in that ICFI ID world, will also be able to have a representative with them at the hospital, or two support people, I'm sorry, at the hospital. And then nursing students. This was a big addition. Obviously, CDPH wants to see more nurses, not just nurses, CNAs, LVNs, everything in it. And the staffing challenges are now, they're just starting to see the same kind of issues that happened to us at the beginning of this are now happening in the acute care hospitals. We know that there are 3 hospitals in the state currently with federal medical workers in them, folks from the Air Force or military, providing staffing resources, on-site staffing resources at hospitals. So this is a real big thing, and CDPH wants to be as supportive as they can to get anybody into our buildings as a new staff person. So, and then outside visitation, defer to the local health department for final say, but it is not specifically approved or denied in this AFL. And then from what I can gather based on the conversations that I've heard through the infection prevention calls, CDPH wants to defer to the local health departments when it comes to what outside visitation looks like. But they have not said that this should not occur. So if you're already doing these and your local health department is okay with them, we say, follow their guidance. And if they say to stop that, either because you have a positive case or because the rate of spread is so high in the community, you'll need to adapt that. If we've not learned one thing during this response is that there's only one constant, and that's change. And it just it seems it's incredibly difficult to do, and if folks have not verbalized how hard it is to change what you thought was best practice on a daily basis and have a process to rapidly take in information and then change operations based on that new information is really difficult. And every chance I get to let CDPH know, or anybody that will listen, is these are data points that we point to and think, why can't we accomplish this? Is because there's 50 other steps that go behind that one thing, and those steps take man hours and they take a lot of work to get done. And folks tend to not see that when they only say, well, gosh, it's just one thing, why can't it be done? So that kind of process, we constantly try to remind them on. The testing timeframes, CDPH is obviously acutely aware of the limitations of this. It is, frankly, we had all those testing supplies at the end of May, and we thought, God, this is going to be a boon, and we're going to always have this surplus so that we could supply not just healthcare, but everybody with the testing supplies so that we can facilitate these counties being able to open back up for the entire community. So we can get schools open, so we can get businesses back open, so we can get restaurants open. All those people rely on robust testing to be able to kind of limit the spread in the community. What happens is those kind of expectations for everybody outside of healthcare has really put a crunch on the testing resources that we have as a state. And so CDPH is aware of that, and they're working to resolve the disparity between the reality of what those supplies are and the goals of the mitigation plans, and how important it is for us to be able to mitigate and or stop COVID from coming into our building. Just know, if it can't be done, it can't be done. There's nothing you can do about it. If you've given your due diligence, you can be confident in the fact that you're doing all you can. You can't do more than what's available. But what we can do is we can document that we did our due diligence. We can take a lot of lessons from the Cal OSHA attorneys that presented a couple weeks ago when they talked about the demonstration of due diligence, of the kind of the thinking process behind saying, I thought this out. This is what I think is best for my staff. It's consistent with guidance, and this is the process that we did to do that. If you can document that, you're doing everything you can, and we're just going to have to wait for that piece to be resolved. because testing is really critical to minimizing the impact to life safety of not just the residents, but our staff as well. Your staff have a tremendous amount of uncertainty. And I just want to share a story that I heard from somebody that tested positive, somebody that's close to us at CAF. And they gave a story about the stigma that they felt from testing positive. And gosh, me thinking, it's the flu. You caught the flu. It's just like that. But it's not like that, because the people that catch this, your staff that catch this, are going to feel ostracized. They're going to feel not a part of. And it's going to be really difficult for them. But it's also the other staff that are uncertain. They're scared to death. I mean, they really are. And so that overall uncertainty can be, I think, can at least be minimized a little bit by having an understanding of kind of what your staff that test positive feel like. Understand that when they go home, they're going to have to call the parents of the children that their children have been playing with. They're going to have to call anybody that they've had contact with, and they're going to have to say, man, I'm positive. I might have given you this. You're going to need to go get a test. And that's a really scary thing. And we all care about the people in our lives. And so there's a real fear around not just testing positive and what that's going to do to us, but also what that does to the people around us and how they view us. And it really wasn't until somebody close to us had given us that kind of insight that we go, oh man, this thing, it's a different thing. And we don't ever want to make our staffs feel like, because something that happened outside of their control, there's a stigma to that. I mean, if you think about, strip it all away, you go, you caught the flu. Okay, you can't work for a couple weeks. I understand. It's okay. You're not a bad person. You don't have to look at everything you've done during the day and said, did I make a mistake? And we don't want people thinking that. We need to kind of pump them up, and it's okay that happened. And we're going to support you through this. And I think it's really important, and it may be important for them to be able to voice those fears and things like that to you. So give them the ability to do that. All right, so I jumped over one thing, but I just wanted to mention that in terms of, we've had a lot of talk about the testing billing for the testing. And of course, we've followed the guidance from Department of Managed Healthcare that essentially said that the plans were required to do testing. The plans came back to DMHC and said, well, there's some language in there that's a little unclear. So what they've done is they created a new set of emergency regulations that's pending now to classify COVID-19 testing as medically necessary healthcare for essential healthcare workers, thus kind of clearing up one of the things that the health plans may have thought removed them from the responsibility of having to pay for these testing. So that will clarify that as well. So that's good news for us. It's something we might not actually see, but it will affect us in the background. So in terms of testing, lots of you guys have seen the press releases from CMS that says point of care COVID-19 testing kits are going to be sent to all the nursing homes in the United States. And we read that. One, we did not know that was coming. And we talked to our partners in other parts of the country, and nobody was expecting this. CAF, we've had conversations with the Sophia, I can't remember the entire name of the company, but back in the beginning of May, when we were starting to understand how testing could really kind of negate it, and we were thinking that more testing supplies were going to come into local health departments, and they would be the one to do this. But I know a number of people early on in this had really identified, well, that's all fine and dandy, but these antigen tests and maybe even some other types of testing that don't have the kind of specificity that a PCR test, they're available and we can use them now. you know, I talked to the president of that company and asked them, you know, would they be willing to approach a CDPH? And because we really think that an instant test at the door is better than waiting 2 weeks to find out the results of the test. And it's even better than waiting a week than finding a test. 80% is better than 0%. And so that's what we're going to ask CDPH is, look, we have these things out there. We know this, the issues revolving around testing supplies will be there indefinitely until we no longer need to test. And if the communities need these testing supplies, just like we do, we're always going to run into this issue of supply, whether it be reagents or transport medium or the swabs themselves or lab capacity. It's always going to be a challenge to line all of these things up in the right order to prioritize us and the folks in the hospitals before everybody else. And so until the counties and the state and everybody can figure out a one-size-fits-all solution, our recommendation is that CDPH at the very least allow antigen tests at the door to be used for surveillance testing. We're going to ask for that right now because Arizona, Texas, and Florida are going to get these devices first. Those are, you know, is it acute as the issue is here? In some other parts of the country, it's still even more acute. I'm not going to say that those states are also battleground states for elections, but certainly there are issues with why certain states seem to be getting things before California does. So our message to CDPH is, if this is going to be a viable solution for surveillance testing, and we cannot have a reliable access to the PCR tests, then let's jump on this now. If there are people that already have this, can they use this to meet the surveillance testing? If people want to go out and purchase these, can they do it? And which ones are allowed? We're going to get those questions answered, and hopefully we'll have them answered long before we'll get these test kits. The best guess that we heard from AHCA right now is that 6 to 8 weeks would be the lead time to when we would actually see the devices. These devices, the tests are much less expensive than doing the PCR tests. And we're trying to figure out how the billing would work for each one of those tests. Would we bill the individual staff's health plan, or how would that go? Because there's something that's not clear. And then could this issue possibly be a method of guaranteeing visitors are safe to come in? And that, you know, that's kind of a second step. The first thing we want to talk about is any kind of testing that increases our ability to protect the folks in our buildings. That's what we want to support. And we want to get in any kind of testing, whether it's antigen or PCR or whatever it is, let's get it to you guys and make it as easy as possible to do it. There's an uphill battle with the local health departments, guys. I realize that tons of you, maybe even more than 50%, are on admissions bans because you have one staff member test positive and your local health department says no admissions for 14 days or no admissions for 28 days. Sadly, the last bullet point there is accurate. The local health department has the final say. But just know these are well-intentioned, and the reason why they do that is because they're really, really concerned that the impact to our folks is much more dire than it is if they were in another setting or if they were, you know, a younger person. So we have to be extraordinarily cautious with that. And that's why the policies are the way they are. Sometimes it's warranted, but in other cases, lots of cases we hear, and of course we hear the squeaky wheels, nobody calls me and says, hey, these guys are doing awesome. Most of the time it's they're calling me and saying, you know, I've got a problem here, or, you know, I'm on day 17 and I was supposed to have my admissions lifted on day 14 and I can't get a hold of anybody at the local health department. Those are the things that we want to hear. even if we can't make a material difference in your particular case, we can build a case for the counties and for the local health officers and say, look, this is not a 9-to-5 job, guys. If you can't dedicate staff to get these approvals 7 days a week, we need you to start that process, or at least, address these quicker. We try. Sometimes we don't have a lot of success at doing that, but we need to hear about those instances where the local health departments are preventing you from admitting long after the time period has expired. All right, so I just want folks to know that if you've not heard on the CDPH calls or kind of the capacity of what CDPH has got in stock now, but it now sounds like PPE in all forms is now in supply. And we've received emails from different counties essentially saying, look, reach out to us because we've got a lot. And so if you're not flush with supplies, now is the time to ask for them. Review your current stock and think long-term. If you've got 2 weeks worth of supply and you're doing extended use on your N95s, that's not enough. Think 2 weeks with normal burn rates. Think a month with normal burn rates. That's what we need to be prepared for. I'm hopeful that we'll have a vaccine at some point, but I think we're probably months away from that at the very best. So we don't know what 2 weeks or 3 weeks from now is going to look like if the rate of spread continues in the communities and the hospitals are impacted. The hospitals are going to start needing those resources too. But my understanding is that the CDPH has lots, like tens of millions. So we'll until they tell us stop asking, let's ask. And don't factor in reuse. At least get to the point where you have enough comfortably to be able to use it under a conventional strategy. And if you're not familiar with the resource requesting process, we're happy to help you out through that. On the CAF.org coronavirus section, there's a link there for the resource request. It's just a blank Excel spreadsheet. You fill out your information. It's pretty easy to do. You just want to be as specific as possible if you're asking for a certain type of PPE. So if you're asking for N95 masks, don't say I need 100 N95 masks. Say I need 35 small N95 masks, I need 120 mediums, and I need 60 larges, or something like that. Be as specific as possible. You can list a make and model that you've used for your fit testing, but it's unlikely that you'll be able to get an actual make and model. But the sizing is important when you make those requests. All right, and so I want to talk a minute about best practices. Forgive me for the silence there for a second. I had to let my cat in. She was making all kinds of noise. Anyways, so best practices, and both the HSAG and Deanne and myself have kind of thought, we do all these webinars, and how we do them is generally a PowerPoint, or it's people talking over a really, kind of dry medium. And that's great because it gives you data points that you can refer back to, and you can, remember what was said and all that. But a lot of who we are as people is a visual. We're visual learners. A lot of us are visual learners. And I thought, God, we've been shooting ourselves in the foot by trying to describe what a lot of these things look like in words, when maybe a picture might actually help better. And so, the HSAG, CDPH, and CAF would like you guys to think about this. We want visual representations of best practice being used. There are folks that don't join this webinar but they're on the statewide webinars. And what we want to do is we want a visual representation of what these look like, so that the providers who are really struggling have at least a visual cue of what this looks like. And they'll be able to look at things and go right away, oh gosh, mine doesn't look like that. It looks like something else. Or mine looks better. Let me send you my picture. You know, things like that. I think it's really important, especially the reason why this came up is because people were sending in pictures of the barriers. And you know, if you send them to me, I'm happy to give you constructive advice in a non-judgmental way. Just say, hey, you know, maybe do this differently or that differently. But it got me to thinking that we could solve this by showing something that's really best practice, but very easy to accomplish. And so those are the examples I want you to do. I want you guys to have your staff through the course of their day. If you have any of these things, and it doesn't even have to be an example of those specific things like cohorting zones or your outside visitation or any break rooms you created for your staff break rooms that are set aside, or negative pressure rooms, or anything like that that you've done. I want to see pictures of it, and we want to showcase your work in front of CDPH. And HSAG is going to put this into their presentation, their statewide webinar, and we're going to do that as an example of best practices. And before you get all nervous about, you know, am I opening myself up to anything? Obviously, don't take pictures of residents. We don't want residents in these photos if you can if you can avoid it. But definitely, if you want to stay anonymous, well, I'm happy to you know, cut out any information that's identifiable about what you're doing. And consequently, if you send me the pictures, I will make sure that we're not sending CDPH something that's not compliant or not within best practice. But I think it's important. I really do. And I think we want to encourage, you know, so much of what we do, we look at what's wrong, and why don't we model what's right? And there's a lot of people doing great work here, and that's not being recognized, and that needs to be called out in a statewide webinar. And we need to help the folks that are struggling be able to visualize what these look like. And so I think it's fun. I think it'll be good. And extra bonus if you can make it funny. If you can make me laugh 100%, you're going to be a winner, at least in my book. And then what I will do is I'm going to give away 2 registration for you and anybody you choose to the CAF Disaster Preparedness Conference in 2021. And usually that's like $250 a pop. So $500 I'm going to give to anybody, anybody's picture that I use on the HSAG webinar next Wednesday as an example of best practice. And it could be any of those things, or it can be your own thing. Any of the winners that we feature on the webinar, I'm going to give free registration to the conference. So I know it's not a lot. I know I don't have any fun gadgets to give away, but at least I will give you the gift of free education. And so if you're willing to send me those pictures, I'm happy to filter those out, and then we'll collate those and pick some winners, and we'll let folks know. But it's about time that we model what we're doing great and show that to CDPH, ask others to share their experiences, and make this a more positive experience. We get too negative and too down, and this is a slog, guys. It's like a long-term thing, and it can beat you up. So we got to try to, you know, change the course here. And like I said, if you want to stay anonymous, or you want your building to be anonymous, I will not tell, you know, I won't say where it came from. But if you want to be credited, by all means, send me your facility information with it as well. And so before we finalize here, I want to talk about this week about kind of the CAF priorities and what we're doing. So I don't know if you know this or saw this in the news, but the AHCA sent out a letter to all the governors for all 50 states this week. And it listed a number of things that that skilled nursing facilities throughout the country have been struggling with, and where the governors could potentially be helpful. And our first item on that list is testing. And if we can't get reliable PCR testing, then we need to get at the door antigen testing. We've got to have it. It really does save lives. PPE. Now I've just told you we've got great news that CDPH has supplies in hand or in stock. We know that certain MOOCs have quite a bit and have proactively asked folks to do that. But the fit testing of the N95 masks is still lagging behind. I still get a number of emails from people trying to either get the competency themselves to be able to do the fit testing for their staffs, but that requires the purchase of a fit testing kit, and sometimes those are hard to find. And then sometimes folks have hired outside contractors to do the fit testing, and sometimes local health departments have pitched in to help train the trainers for fit testing. Our point is that there is no consistent ability for us to fit test our staff, and that's a real low point because we can't give them the best protection without being fit tested. Well, I shouldn't say that we can't give them the best fit test or best protection. We can't guarantee that they're wearing the mask exactly how it's intended without at least making sure they're fit tested for that specific mask. And Cal OSHA, that's why the requirement is the way it is. And our advocacy to Cal OSHA has been and continues to be that that's fine. We have a few fit tested folks on our staff, and those are the folks that take care of those airborne isolation residents until we can transfer them out. But we've not been allowed to do that since April. So what are we supposed to do? We now have these folks in the building. We can't transfer them out. We have to accept admissions of COVID, or maybe not, or maybe COVID came into our building and now we have an outbreak, and we have to have people to treat those folks. So there are a lot of things that just kind of hit everybody at once that exacerbated the fact that we could not do the initial fit testing. And those resources are still scarce and scattered and not consistent. And so that's our message to the governor. We've also asked the governor to really put an emphasis on visitation. I know we look at the risk of having somebody come in and expose an individual, but there's also a risk, the psychosocial risk, and how that affects folks' health. And so there's an impact by not having visitation. And so really kind of partnering the testing with visitation in order to be able to start visitation back up. And then I want to talk for just a second. Next week, we've got Dr. Alexis Kennedy from UNLV. She's a professor at UNLV. She's a trainer on a bunch of different mental health topics, but specifically compassion fatigue with folks that work in this field, even the ones that are administrators that are maybe not even doing direct care. There's a thing called compassion fatigue and the mental health that exposure or risk that we feel leading folks in a response. It's a real thing, and most of us didn't even, well, I didn't have a language for that up until a few weeks ago. And so I think this is a great presentation because it really talks about some physiological things that happen within our body that are outside of our control, and recognizing how our feelings are really affected by physiological things that are going on in our building or in our body. Sorry. And I thought it was a really good presentation. It certainly was for me, but hopefully you guys will get a lot out of it. Dr. Kennedy speaks to the QIO programs in a a number of other states. And so I saw her on a QIO webinar, and that's why I asked her to come on in California. So I think you'll get a lot from her presentation. So I highly recommend that you guys attend that one. It's, the price can't be beat. It's free, and like all of our webinars, that will be recorded as well. So Courtney, did you want to go over some questions, or did you want to talk about the CE portion of it for just a quick second while we've got more attendees on there?
Sure. So you can hear me okay, right?
Yep.
Okay, great. So just a reminder, if you want the CE hour for these COVID weekly roundup webinars, you'll need to register on the CAS website. And then before the webinar takes place, you should receive an email with the GoToWebinar link. So it's a two-step process. And if you are having trouble finding the links or getting the information, please reach out to myself or someone at QUAF or CAS, and we're all working together to try and get that information to you and make sure that the registration process works well for everyone. And that's all I have to say about the CEs. If anyone has any trouble finding a past webinar, let me know and we can try and get that sorted out for you. And we have a handful of questions in the chat box. So Jason, if you're ready, I can go ahead and move to the first one here.
Yeah, go for it.
Okay, so our first question, what is your guidance on completing physician orders for COVID-19 surveillance and response testing?
Oh gosh, I'm not quite sure what that refers to. I tell you what, is there an email on that response? Whoever typed in that question, can you send Courtney your email, and I will have Deanne answer that question. I'm assuming they're asking about do the physicians have to order the tests for either the staff or the residents? But I'm not clear. And a part of that emergency regulations that I talked about earlier, that would negate that need. I believe that was one of the intentions of the emergency regulations. But if you send Courtney your email address, I'll give you a specific answer, and we'll get it from Deanne for sure.
Absolutely. So Melissa, who submitted that question, will follow up with you afterward, and I already have your email from our GoToWebinar platform. So moving along to our second question from Kevin. When transitioning someone from the COVID zone, are they required to be placed in the PUI zone since they no longer display symptoms? If so, how long?
No, if they meet the time-based criteria, well, it depends on, are you doing the time-based or the test-based? And I probably screwed the name of that because they change it all the time. But it's essentially, they're positive. If they have symptoms, then you wait till the symptoms resolved, and then it's an additional amount of time on top of that. But once they have reached the point of time where you remove them from transmission-based precautions, they're free to go back into your green zone. But you can be as conservative as you want, certainly, but there's no, the thinking is if they're free to be off transmission-based precautions, they're no longer contagious. And so if they're no longer contagious, we can put them into the green zone. Now, your guess is as good as mine if that's if that amount of time is adequate or not. I think by the time we get to the end of this thing and it's all over, we're going to find out you could stay contagious for much longer than what we had originally thought. I mean, that may be one of the reasons why we see outbreaks occur again at facilities. But I'll say that you can't really, when you make those decisions in your building, you can't really think, well, gosh, the one off is going to be the one that gets me. You got to go, well, CDC says this is best practice. We're going to follow at least the best practice, and then if we get bit by it, then there's not a whole lot we could have done about it. All right, next question.
Okay, if a staff member goes on vacation traveling out of the area, including out of state, should that person be required to be on a 14-day quarantine before being allowed to return to work?
And it's just travel and that's it?
Travel out of state.
I don't know if that is the sole, I don't think that's the sole sole factor. It would have to be travel out of state to a specific area. Yeah, I don't think so. I don't think you would. I mean, if the person's not symptomatic, before I give a concrete answer, I'll double check that because I don't think they would. But you know, sometimes I spout off and give an answer and I'm wrong, so I will find that out. But I don't think just travel itself and by itself would exclude them. But I'll double check. And do you have an email address for that person as well, Courtney?
Yes, I'll follow up on that one as well.
Okay.
Next question. If the point of care test that CMS is deploying only has an 80% accuracy, how will that affect the reporting that is currently being done for cases? Will the guidance be updated to accept this lower accuracy?
Yeah, that's what we're hoping. And it's not because we want to support a less robust testing method. On the contrary, it's because we think that this has the ability to be much more effective because we can operationalize it, and the testing promises to get results back much sooner. And until we can get a reliable PCR test, we may have to do this thing where we transition back and forth from that. But I think for surveillance testing, if we're not getting tests back very quickly, then 80% is better than none. In terms of what we ask CDPH, we're going to advocate that this be used and be accepted for surveillance testing. And that's really important because that's where this is tailor-made for that type of testing. When we're doing surveillance testing, we're not testing 100% of the staff every day, right? We're testing them once a month. And so if we can get one of these devices and we can test people once a week, and it's 80% accurate. Well, I shouldn't say 80% accurate, but it does have some false negatives, and that's the concern, obviously. But if we're testing once a week at 80% versus once a month where we have to wait a week or 2 weeks to get results, well, we're getting a much better look inside of what's going on in the facility if we use that for surveillance testing. Now, for response testing, the antigen test highlighted you had one positive case in a staff member, then you're going to come back with the PCR testing and you're going to test everybody, and that's going to give us a true look of what it is. But at this point, it is much better than what we currently have, and so that's why we want to encourage that. Next question.
Let's see. Someone asked, hi, please review the information about the emergency regulations. I'm assuming in reference to the first question we had about ordering the testing, about the physician orders. Is that being proposed or in effect now? Thank you.
Yeah, it just came out yesterday. I just got a copy of it yesterday. Let me see. Tell me if does that mess up the screen when I do that? Can you see?
I don't see any change.
Oh, okay, because I had to get off that to look up the link. But there is a link to didn't I put the link on the bottom of that? If you click on that link that's on that screen, so if you downloaded the slides and you just click on that link in the slides, I think it's WAPO something or other. Well, you know what? Let me go back on the slides, see if I can go back on the slides and I can pull it back up. Yes, right there. So that's so that link right there gives you the exact language of the regulations. I just cut out what it really is targeting. It's going to classify all those things, and it talks about whether a doctor has to order it or not. I didn't put all of that in there, but yeah, it's definitely in. All right, next question.
Okay.
I think if you read that, it will give you all the answers that you need for that.
Okay, great. Next question. If a staff was positive and retested after 8 weeks and positive again, what is the recommendation for that staff?
Well, they're gonna fall under the same time-based criteria to hold them out for that 14 days or wait for symptom development. But I mean, it's very interesting because we've gotten indications that some folks, not everybody, but some folks can remain persistently positive with COVID. The current research is that even the folks that stay persistently positive, they generally run out of that at about the 6-week mark. And so by 8 weeks, that should be resolved, at least based on the most recent research. And I don't, and so that's why I kind of think why they put the 8 weeks in there. I haven't heard about people retesting positive again at the 8-week mark that are not actually reinfected. And so that's the question that nobody knows the answer to right now. And so a part of that retesting strategy will be to determine, did this person just stay persistently positive, or is this a new infection? But definitely if they hit that 8 weeks and they test again, the guidance from CDPH and CDC is they go back into the same protocol. You start your response-driven testing all over again. It will really suck. But the hope is that we're not going to see anybody at the 8-week mark that's persistently positive. It generally should resolve before the 6-week mark. So at 8 weeks, we should be okay. All right, next question.
Okay. During a survey visit to a COVID wing that is closed off from the rest of the facility, the residents did not have masks on and their room doors were open because they were eating lunch. The surveyor stated she was concerned with the doors being open and their masks being off. Is there a standard about meal service, mask use, and doors needing to be closed at all times for COVID positive rooms?
Well, gosh, common sense says if you're eating, you probably can't have a mask on. So we know, that that part should be obvious. There is language, that basically says, we're going to try to get the residents to wear masks if they tolerate it, but if they don't, we can't force it on them. But definitely if they're out of their room. But if they're in their room, no, they don't have to wear their mask. And I mean, just doesn't make any or makes little sense. I know folks get scared and they go, oh, well, we're just going to be more conservative all the time. And you got to think, well, look, this person sleeps in there without a mask on. It's okay if they're laying in their bed and eating without a mask on. Yes, that is okay and it's acceptable. In terms of having the doors open or closed, those are not requirements, they're recommendations. I think it's probably a good practice to have, but we get back into this thing where, there's that kind of psychosocial aspect and folks feel closed off and maybe feel isolated if the door's closed. So it's one of those things you definitely have to thoughtfully consider. But if your COVID wing is separate and you're doing all that other stuff, I don't know. It's a toss-up. I would try to keep the doors closed if I could, but if folks needed they were going crazy and the other option was they were going to come out of the room if the door was closed just to be able to get some fresh air, then obviously it's better to have them stay in their bed and keep the door open than have them wandering the halls. So depends on what the situation is going to cause by having the doors open or doors closed. But if you can do it, I think best practice is to do that. But the masking of the staff certainly, or residents while they're eating, is impossible. And we want to give them the mask, encourage them to wear the mask. If they're outside their room, they're definitely wearing the mask. But if they're inside their room, there's no requirement for them to be masked. And I don't know that it's realistically possible to ask folks to do that. All right, next question.
That looks like it was our last one, and we are just about to hit 2 p.m. So Jason, do you want to wrap things up?
Yeah, that's great. Thanks, guys, for joining us. Thanks again for all that you do. I know it sounds like lip service when you hear folks talk about how much they appreciate what you do, but this thing's has gone on for way longer than any of us ever thought, and we just go, huh, is it really again? Yeah, sadly it is, but we're doing okay. We're doing good. Folks in this space have for the most part they've dived right in, and if you ever want to see what a hero looks like, just look at the folks the next time you come to a CAF meeting. Those are the people that were in it with you. They're in the trenches, and I know people outside don't realize this. They don't get a picture of the flavor of what happens in our buildings, but you guys are immense heroes in my book. I can't thank you enough for what you do. If you ever have any questions, and especially if you've got pictures. Oh, I forgot about this. So my email address is jbeld like David, en like Nancy, @caf.org. You send them to me, the pictures to me or Courtney. We'll look through those pictures, and I promise you I will make it worth your while if we pick your pictures for the webinar. So I want to thank you again from the bottom of my heart. We will look forward to seeing you next Friday for our webinar with Deanne. And thanks again to Jamie and Courtney. You guys have a great weekend. Take care.